Hello and welcome everyone to this team FRCR 2B session today on MSK module. I'm really thankful for all our volunteers who will act as examiner and examinee. So the first duo of volunteers would be myself and Dr. Mahak. Dr. Mahak would act as the hot seat candidate, and I will examine her at the moment. Dr. Mahak, can you unmute yourself? Dr. Mahak? Yes. Yeah. Okay. Okay. Can you see my screen?
Yeah, I can see.
Okay. You can start, Dr. Mahak. This is 50-year-old male, shoulder pain, deformity, and swelling after a minor trauma. Okay?
Okay. So I can see. Okay, so can I choose the projections, or you are going to?
I will give you the mouse. Okay.
Okay. I have been provided with anterior posterior.
You can control the screen now. You click on your the screen with your mouse, and then you can take the control.
Okay, fine. Okay. I have been provided with anterior posterior radiograph of right shoulder joint in internal rotation, and when doing it systematically, I can see recesses in the medullary part of the right humerus with cortical pinning and displaced. I suspect displaced fracture in the mid diaphysis. So I am looking at the other views. On this view, and in the internal rotation view, and there is overlap between the glenoid and the humeral head with loss of normal articulation between the in the glenohumeral joint. And on oblique internal rotation view, this is quite evident. And on wide projection,
ignore this Y view. Ignore the glenohumeral articulation. Can you describe the osseous lesion for me, please?
Okay. This is a long. This is a linear osseous lesion primarily centered in the medullary canal with endosteal scalloping and cortical thinning as well. I can see some thin septations in it.
Good.
And this is with a narrow zone of transition, but it is quite quite a disseminated lesion in the diaphysis. So in this patient, I presume this is an adult patient, so my differentials would be polylytic lesions like lymphoma and metastasis can present in this way.
Can you, do you need anything, do you want to ask for something else before giving me the differential? Can you show me can you pinpoint the lesion for me?
I guess this is the lesion actually.
Okay, this is, you're showing me the proximal end, right?
Yeah.
Can you show me the lower extent, please, of the lesion?
The lower extent, I guess there is a pathological fracture. So the lower extent is not visualized. So I would request a view of the whole arm for this.
Very good. Your next step would be that you would ask for an X-ray of the whole humerus.
Fine.
Okay, go to number 3, please. Click number 3. So here you are.
Yes, I can see the lesion and the displaced fracture very well on this view, and it is extending from proximal metaphysis to midshaft and going somewhat distally till the it is sparing the lower 1/3, the distal 1/3 of the humerus, and there is impression of some soft tissue associated with this.
Can you show me the soft tissue component? Where is the soft tissue component?
I guess this is the soft tissue.
What do you mean by the soft tissue component here?
Means the lesion, I guess this is an aggressive lesion that is associated with a soft tissue component.
Okay, so so you think this is an aggressive lesion?
My first differential would be for a non-aggressive lesion, but seeing this, I think it's aggressive.
Seeing what, the fracture?
Yeah, like the whole view of the lesion, and I guess this presents mostly like a metastasis to me.
Okay, can you describe me the features which is pointing towards the aggressive lesion in this particular case?
There is endosteal scalloping and cortical thinning in this lesion.
Okay.
Yeah.
You said cortical thinning and endosteal scalloping, right?
Yes. Yes.
Okay, so your final answer is that's an aggressive lesion?
Yeah.
Okay. We did a CT in this case. Click number 4, please. You can scroll any one you want. I think the one which is clicked should be fine for you. Go ahead. The other one are for biopsies. Click on the screen and then scroll. No, click on the screen on the side, on your right-hand side. And now try to scroll. No, outside the box, Dr. Mahak. Yeah. Now try to scroll. Sorry. I think this is just static image. Okay. This is a static image. On this static image, what do you think? What can you see in this soft tissue window?
I can see a soft tissue lesion in replacing all the medulla of the bone here. And there are evident cortical breaks. I think section is from the fracture, pathological fracture has occurred.
Okay. I think it is unfair that this is not scrolling. Let's leave this. I'll just go to the next case. Click next. Okay. We'll just stay on the X-ray. Okay. Good. Yes.
Okay, I have been provided with anterior posterior view of bilateral knees of an adolescent patient in the maturity of the bone. And in the first impression, I could appreciate dense metaphyseal bands. The transverse metaphyseal lines are evident on this view, and let's see other orthogonal view. Similar findings, dense metaphyseal bands on the distal aspect of the femur and proximal tibia as well as fibula. So here my differentials would be.
Can you tell me some negatives?
There are there are no associated osteopenia or periosteal reaction associated
Excellent.
with this. There is there's no soft tissue component here. The soft tissues around the joint appear normal to me.
Okay. So what is your differential? Go ahead.
Dense metaphyseal bands, they could appear in a variety of conditions like lead poisoning in children. Might have taken some.
Sorry, I'm missing you. There is a lot of echo. Can you repeat again? What is the differential you told, Dr. Mahak? Sorry.
Dense metaphyseal band, it could occur in lead poisoning in children.
Lead poisoning, okay.
Yeah, after taking after lead ingestion, and they can also occur in healing rickets. But I don't see any bowing or any other deformity which could which could suggest me a previous insight of rickets. So, and they can in children they can also occur in some conditions like sorry.
It's okay. It's okay. Go to the next case. Click next. It's fine. You are doing good. 14-year-old female, painful feet. You can see all the views at your discretion.
Okay. Okay. I've been provided with oblique projection of right foot, and
see all the radiographs, Dr. Mahak. See all the radiographs
once,
and then you can start. describing?
Okay, I will first describe this. I can see on the lateral view, I can see talar detail
Good.
on this lateral view, and
Can you
I
pinpoint the talar beak, please, for
yeah,
me?
this is
Excellent.
this
Yes.
okay, and I suspect there is talar some collision in this case. So this is obvious on this oblique view that there is a pterocalcaneal collision.
Which collision again? Sorry.
Sorry, the calcaneal navicular. I'm sorry.
Excellent. Okay.
Giving an anterior low spine. So this would be the cause of the pain. I'm sorry. Is it
Okay.
fine now?
Okay.
The
Go to
sound?
the next case. Good. Well done. Go ahead. Let me give me one moment. Let me disable the chat. Otherwise, it will disturb us in between. Okay, we'll do it next. Just a request to the attendees, do not discuss the diagnosis during the hot seat. Okay, go ahead, Dr. Mahak.
Okay.
It's a 10-year-old male.
I have provided with lateral X-ray of a 10-year-old male, and I can see there's an extensile lytic lesion in the mandible, and it has a sort of bubbly appearance, and it is involving the whole of the mandible, and this is also involving the other parts of the facial bones on this view. I it on the frontal view, yes, it is involving both the maxilla and the mandible and the zygomatic bones in the face. So my primary I cannot see the chest also.
You can see the chest as well, and look at the lateral again.
Okay.
And tell me which bones are involved.
It is involving the mandible and the
Can you describe the lesion for me? How does it look?
This
What is
is
the
the
appearance?
lesion. It is causing loosening of tooth. This is the lesion.
Yeah. So what are the features here which you can see in this lesion?
Yeah, the lesion it is quite a well circumcised lesion with cortical thinning, and there are no evident cortical breaks in it. And it has this bubbly also bubble sort
Excellent.
of appearance with ground glass matrix.
So what is your diagnosis?
So my diagnosis here would be fibrous dysplasia cherubism.
Sorry, fibrous dysplasia. What
Fibrous
did you say?
dysplasia. So cherubism.
Cherubism. Okay. 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 Can you check number 3? I think it's CT. Maybe we can. Okay, leave it. Leave the CT. Let's go to the next one. You have already described it. Well done.
Okay.
We've got 30 seconds. Go to the next case.
Okay. Because anterior posterior view of the pelvis with both hip joints. Here I can see bilateral symmetrical areas, lobulated areas of dense mineralization in the projecting over the hip joint and the lower half of the pelvis and extending in the thigh region. So if the patient had a paralysis or a failure spinal insult, this could represent heterotrophic ossification. And,
do you see the cause of your heterotrophic ossification in this X-ray? What do you think?
I think there is the soft tissues.
Yes, I agree what you said.
Yeah.
But is there anything else other than the heterotrophic ossification?
It could represent myositis ossificans.
Excellent. But do you see the reason for this myositis ossificans here?
For that.
Maybe you have said it and I have missed it because of the echo. Okay. You did it very well, Dr. Mahak. Well done. Let me give the feedback, and I'll take the mouse control from you. So did you mention this? Did I miss it?
No, I didn't mention.
So this is a radiopaque foreign body This patient has history of gunshot wound. Okay, so he has trauma, he has spinal cord injury, and hence, as you said, this is myositis ossificans when there is traumatic injury, right? Now, the heterotrophic ossification, as you correctly said, that it can be because of 3 reasons: either traumatic, which leads to myositis ossificans, okay, or neurogenic, like a patient has spinal cord paralysis or some neurological deficit because of which he's not using his lower limbs. And then you'll see diffuse osteopenia, and with time there would be heterotrophic ossification. That's the neurogenic cause. And then the third is the hereditary cause. That is the myositis ossificans progressiva. Okay, that is congenital. But this one, you can say in the exam that because I see a radiopaque foreign density, which is rounded, most likely a bullet. So this patient must have gone through some traumatic injury, which has led to this, most likely to some sort of paralysis, which has led to bilateral myositis ossificans in this case. Okay, well done. Okay, let me, yeah. So this was well done. The next case, as you said, this is cherubism. What all I wanted from you is to, when a case then just describe it as much as you can. Use the word expansile, use the word cortical thinning, use the word that innumerable tiny lucent lesions with well-defined margins and narrow zone of transition noted in the mandibles. I do not see any associated soft tissue. I do not see any cortical break. I do not see any periosteal reaction. All you see is cortical thinning, right? So this is, as you correctly said, is cherubism. This can be followed by a question of McTune-Albright syndrome. Every case, they usually follow it with a Viva question, a pertinent, which I'm sure you know the precocious puberty, which is associated with it, right? So well done. Here in the calcaneo-navicular coalition, you did very well to use the terminology of talar beak. Okay, this talar beak is also seen in the talocalcaneal coalition, but also in calcaneo-navicular because of the dynamics which changes, right?
Yes.
Now the question is, you do not see the proper fusion, is it?
Yeah.
You can see the navicular separately, and you can see the calcaneum separately. So the question may arise: how are you saying that this is coalition? Why is this coalition? Because I can see the joint space of the rest of the bones, right? They are very clear. There is no sclerosis at the end plates, at the articular surfaces. But here, there is sclerosis. So this is the sign of coalition. Okay, so describing it during the exam would be nice, so that the examiner would know that, of course, you have said that this is calcaneo-navicular coalition, but just describing it, saying that I can see that there is narrowing of the calcaneo-navicular articulation with sclerosis in the periarticular region, and there is talar beak bilaterally. So hence, this is a case of calcaneo-navicular bilateral coalition. Okay, well done again in this. Okay, this dense metaphyseal bands, these cases would always be as a differential. You will give a differential, and the examiner might or might not guide you to the final diagnosis, because that's not his concern. His concern is whether you can describe it properly, as you did, that there is transverse, symmetric, dense metaphyseal bands. And sometimes, at least in the courses I have seen, they leave the answers on the screen, but in the real exam, it might not happen. So as you said, in the distal femur, proximal tibia and fibula, and you correctly gave the differentials, lead poisoning. You also said healing rickets. Other differentials, the magic 3, at least no 3 differentials. So for everything, so that the examiner would be okay with it. Of course, it can be something.
Actually, I was a bit apprehensive. It was my first Viva.
No, you did extremely well. You did extremely well. Please do not take it personally. I'm just saying, even I would forget when I'm on the hot seat. But just for our own reminder.
It was a blackout for me. I had memorized.
Sure. No, you did very well, Dr. Bahat. Of course. Even I would black out. Just wait and see what happens in your case turn. And other cases are chronic anemias, like in thalassemias and sickle cell disease. There you also see this dense metaphyseal bands, post-chemo, post-radiation, treated leukemia. All these are list of dense metaphyseal bands. One point is that if you are suspecting lead poisoning, you can check for urine porphyrins, okay, just for the sake of Viva. if the examiners ask you, how would you know about lead poisoning? Urine porphyrin is an indicator of lead poisoning. Okay, this one was interesting, and I myself put it like this because even when I was seeing this case, I just made my mind on this X-ray alone. Okay, the proximal humerus. Okay, this is a solitary lesion. This is well defined. This is lucent. There is a pathological fracture. There is a narrow zone of transition, but I cannot see the distal end of the lesion, right? I should not be giving a diagnosis unless and until I see the whole of the lesion. So once you see the whole of the lesion, see, you should say that this is a well-defined lucent lesion, narrow zone of transition. There is cortical thinning with cortical break, a pathological fracture with overriding fragments. Can I convince you? Can you see a dense bone fragment here?
Yes.
At the dependent part.
I haven't seen such a long.
Maybe it's not. Maybe it's not very clear on the Zoom. So that is why this is a fallen fragment sign. This is a simple bone cyst. Okay, and I totally agree. This becomes confusing that this is soft tissue, but actually it's a very well exposed X-ray. So what you're seeing are the muscles. Okay, these are the muscles. These are the muscles. So there is no soft tissue component. There is only a pathological fracture in a very well-defined, lucent, benign, non-aggressive lesion. And the top of the differential will be simple bone cyst because of the fallen fragment sign. Okay. You did very well, Dr. Maha. Thank you so much for volunteering. Now you go ahead and share and just see how I now.
I'm sure you will.
Go ahead. I will keep track of the timer, and at 30 minutes, I'll let you know so that we'll make it the last case, okay?
Can you see my screen?
It has started sharing. We'll be able to see in a while. Yeah, I can.
Okay. Carry on.
Okay. Can I request remote control from you? I have asked for the remote control.
Yes,
okay. Okay. Yeah. So pain in the arm associated with swelling, 25-year-old male. Okay, so these are the AP and the lateral views of radius and ulna in a skeletally mature patient who has presented with pain and swelling. What I can see in my provisional finding is that there is cortical thickening in the mid-shaft region of the ulna. There is encroachment in the medulla with this cortical thinning. And I have suspicion of a lucent area within this eccentric cortical-based lesion. I'm looking at the rest of the bones to see for any other pathology or fracture. Apart from mild osteopenia, I do not see any other abnormality. So considering that this is a young patient with who is symptomatic, with this cortical thickening and suspicion of a lucency in between, I would consider osteoid osteoma as my prime possibility. And I would ask the patient if he has the nocturnal pain and whether it is relieved with the NSAIDs, and would advise a CT or an MRI for further evaluation.
Okay, and what would be your other differentials?
The other differential could be chronic osteomyelitis. I would ask him if he has previous history of infection. That would be my second differential.
Okay, what would you prefer, CT or MR?
CT.
Okay. Okay, you can go to the next case.
Oh, next case?
Yes.
Okay. I'm sorry. I think you'll have to take me to the next case because my own screen is getting obscured by my screen.
Okay. Let's see.
Okay, 13-year-old male. So this is a hip X-ray of a 13-year-old male In frog lateral view, I believe, I'm looking at the hip joint and at the epiphysis particularly to see if there is any slip actually. I do not see any displacement of the epiphysis per se. I'm trying to look at the joint space, the right and the left. I don't see anything. I'm going to go systematically now and look at the bones. So I'm looking at the left iliac bone, and I can see that there is a permeative lytic lesion involving the left iliac blade with cortical break, periosteal reaction, and a soft tissue component. In this young patient with such an aggressive lesion, I would consider Ewing sarcoma / osteosarcoma as a prime differential, with osteomyelitis less likely. I would immediately discuss the findings with the clinician and advise further imaging with MRI for further evaluation and to see the extent of the disease. And if it comes out, and would refer him to a specialist sarcoma center for biopsy and further staging if it comes out to be an Ewing sarcoma or osteosarcoma.
Okay, like how would you differentiate between Ewing's and infection clinically?
Clinically, yes. Clinically, actually, fever, yes, but fever can also happen in Ewing's as well. I would ask about the duration of the history. Clinically speaking, actually, I
Yes,
believe
that's important. You have to ask for duration of the history because fever, leukocytosis that can all occur in Ewing's as well as infection.
Right, right. So I would ask
Yeah,
about the duration. Yeah.
yeah. So you did well. This was sort of an edge of film case. Please turn to your next case.
Okay. So this is 1 year old, no history. Okay. So this is the frontal view of both lower limbs. I don't know if there's any difference. So what I can see is that there is metaphyseal flaring and spurring, and there is osteopenia of the epiphysis. There is, I'm looking for any, there is elevation of the periosteum along the distal aspect of bilateral femur. So I believe this is a case of scurvy with this Wimberger sign of pencil thin epiphysis with subperiosteal hemorrhages with the Pelton spur. I would discuss the findings with the clinician and ask for the vitamin C levels to confirm the diagnosis, and the patient would be referred to pediatrics for further treatment.
Okay, what would be your other differentials?
Sorry?
What would be your other differentials?
In a child, I would also be thinking about rickets. But in that case, I wouldn't be seeing this pencil thin epiphysis. There would be more of, coming to think of it, maybe the other differential would be rickets. I'm not really sure at the moment. Initially, because of the epiphysis, I thought that this is scurvy, but rickets, yes, because of the metaphyseal flaring and widening, this could be rickets as well. And in that case, I would ask for the vitamin D levels.
Okay. So next, please.
Okay, so this is a 34 weeks gestational age child, delivered normally, short limbs and desaturation, newborn.
This is a premature child. And there is a survey.
Okay. So I've been provided with multiple images: the bilateral lower limb, the upper limb, and the hands. Okay. So what I can see in the hands that we have short stubby fingers. Here I can see that there is square-shaped iliac wings. There is a shortening of the extremities. There is bulbous configuration at the ends of the long bones in both the lower and the upper limbs. The findings, I have the prime differential of achondroplasia, considering the iliac wings, the short bones, and the stubby fingers. So I would discuss it with the clinician and give the prime differential of achondroplasia. Also, there is the visualized sacrum. There is narrowing of the interpedicular distance as it goes down. So achondroplasia, and the patient would be referred to specialist pediatric for management. Okay.
I have withheld the history.
Okay. So I have been provided with the AP, oblique, and the lateral views of both hands. So what I can see that there is a bilateral symmetrical arthritic process involving both hands, with predilection of the radiocarpal, the carpal, and the carpometacarpal articulations. I can also see that there is a decreased metacarpal phalangeal affection, followed by the proximal and the distal interphalangeal joint, but there is very clearly a proximal preponderance. I can also see that there is flexion deformity at the interphalangeal joint, with flexion at the proximal interphalangeal and extension at the distal interphalangeal. There is also subluxation of the proximal interphalangeal joint towards the ulna. So I believe, and there is gross osteopenia. The first differential which comes in my mind is rheumatoid arthritis, considering its bilateral symmetrical and proximal arthropathy preponderance. I will discuss with the clinician and ask about the rheumatoid factors, and would also ask the patient if he has any, the clinician, if the patient has any respiratory symptoms, then a chest X-ray followed by an HRCT would also be recommended to see the pulmonary manifestations of rheumatoid arthritis. In short, this patient would be referred to rheumatology for the management if the patient is already not being followed up there.
Okay, what else it could be? Okay.
Osteoarthritis would actually affect the distal interphalangeal joint more as compared to the proximal. That's why I did not keep it in the differential. Psoriatic arthritis,
why
again.
It is not atypical erosive osteoarthritis.
Erosive osteoarthritis, yes, you are right. It would usually have a gull swing appearance, which I can only see here, but I was considering it as a part of rheumatoid arthritis. But considering this joint affection, yes, maybe erosive osteoarthritis could be put in the differential. Again, I look at the rheumatoid factors and then reach a final diagnosis in this case.
Okay. So please describe the sagittal T2 weighted image only.
Okay. So this is the sagittal T2 weighted image of a lumbosacral spine, which is showing saccular morphology of the dural sac, which is, I can see the posterior vertebral body scalloping. I'm looking at the cord. It seems to be terminating normally with quadra equina morphology. I'm looking at the axial images. Sorry. So in the axial images, again, there is expansion of the spinal canal with a lobulated morphology. I think this is axial, or this is coronal?
This is, I guess, coronal.
Yeah, this is coronal. So basically, I'll go back to the sagittal T2. I believe this is with the posterior vertebral body scalloping. Achondroplasia can be one differential. I can also see that there is decreased vertebral body height and superior end plate depressions. Dural ectasia itself is another differential. I do not see any neurofibromas. However, dural ectasia can be seen in neurofibromatosis as well. Maybe the neurofibromas are higher up in the thoracic or the dorsal spine.
This case was all about differentials. So what are the differentials of dural ectasia?
Yes, for the dural ectasia, it can be achondroplasia. It can be neurofibromatosis. That is the two differentials which is coming in my mind at the moment.
Okay. You can memorize it like men in Marfan's and Allen and as a connective tissue disorder.
Okay, okay. Dr. Mahak, my time is up, so now you can go to the feedback.
Okay. So you did well in this case. There was posterior scalloping plus dual ectasia. So this case, I had basically kept it for the differential sake. This was a case of neurofibromatosis, although on this image we can't see any neurofibromas.
Right.
Yes. And Down syndrome, dural ectasia can also occur in Down syndrome.
Exactly. You're right.
Yeah, you did very well in this case. It was actually rheumatoid arthritis. And then you can mention, you describe all the findings very well, but still, I guess you can overadd it, like there was soft tissue swelling, I guess there was very
right.
Yeah,
yes.
And plus, we were always, like I always do this, I'm always busy describing the hand and I forget radius and ulna. So, don't forget to say you can see ulnar styloid erosions also.
Yes, absolutely.
Yeah.
Yes.
So you did very well in this case. Yeah, this was achondroplasia. Just a minute. So in this case, there was rhizomelic dwarfism, and you described all the findings very well. There was weakening and metaphysical resenses, and they like you can see they are the clowns mostly in circus we see, and so they are stubby. So increased skin folds. So always look at the soft tissue and skin also along with the bones. So this was a takeaway message.
Right.
Okay. And this case. Yeah, this was curvy actually, and because there was no bowing, and the epiphysis thin, it shows a typical Wimberger sign, and the dense metaphyseal. In rickets we find metaphyseal flaring, and it is sort of lucent. And there is dense metaphyseal band here, the what we call as tromophyll zone and the white line of Frenkel. So this was white line of Frenkel, and just adjacent to it there is tromophyll zone. So it's not very well seen the tromophyll zone here, but obviously white line of Frenkel and Wimberger sign plus the subperiosteal elevation you can see very well. So this was curvy.
The take-home point is, if the examiner rattles you, don't get rattled, right?
Yeah, be confident. Yeah, this is curvy.
Yeah. Okay.
Yeah, and this case I have kept it as like the edge of the film case. No? Like when I was watching it, I took it as I think it's a bowl. Yeah. Then I took it like no, I have to see it.
Yeah, it's a great case. Yeah.
So this was Ewing's only, and the differentials were good. Okay, the first case. Yeah, this was osteoid osteoma, and one differential you can add is stress fracture also sometimes, but it is very unusual on the inner side of the ulna. So the two main differentials would be osteoid osteoma and chronic osteomyelitis, in which we can see the suppressed in the lucent phase. So you did very well, Salah.
Thank you, Dr. Mahak. Excellent cases. Thank you so much. And thank you for the feedback. If you would stop sharing the screen, then next is Dr. Ubada and Dr. Mamoona. Dr. Ubada, yes. Dr. Ubada, can you share your screen, please? And Dr. Mamoona, you'll be the candidate.
Yes, just a second.
Yeah, sure. Take your time.
Projecting.
Yes, it's fine. We can see it. Dr. Maimuna, can you say hi?
Yes,
Oh, okay.
yes, I'm
Over to
here.
you guys. Go ahead.
You can start. This is
okay.
the presentation.
Okay. Okay, this is a case of collapse, left arm held in abduction and external rotation. Patient's age is 80 years male.
This chest X-ray was done for the collapse of the patient.
Okay. Okay, this is a frontal projection chest radiograph of the same patient. I cannot see any visible abnormality in bilateral lung fields. There is no area of collapse or consolidation. The cardiac shadow and the mediastinum appears normal. The costophrenic angles are normal. The trachea is central. I can also see the left shoulder, in which there is the bones show generalized decreased bone density, and the hand is in abduction, and there is a loss of congruity at the glenohumeral joint. So I'll suggest a radiograph of the shoulder to further take my case.
This is the shoulder.
So this is the shoulder radiograph of the same patient, in which there is loss of normal articulation of the glenohumeral joint. The radial head is inferiorly displaced, and I can also see some cortical break along the posterior margin of the left glenoid cavity, which is suggestive of Bankhart's lesion. And so this is anteroinferior dislocation of the shoulder with Bankart lesion, and I'll suggest an MRI to look for Hill-Sachs lesions, and the patient needs urgent orthopedic referral for management.
Okay. Urgent reduction was done at the ER, and this is a post-reduction X-ray.
Okay. So this is the frontal projection radiograph of the shoulder of the same patient, showing relocation at the left shoulder joint, and I can see a detached bony fragment along the superior aspect of the humerus, which is suggestive of Hill-Sachs lesion, and so this might lead to chronic dislocation, and the patient should be followed up.
Okay, so you said this is anterior inferior dislocation.
Yes.
Can you tell me what the types of the shoulder dislocation
This is commonly the most common type is anteroinferior dislocation, but in some cases, patient also develop posterior dislocation. In cases of electrocution or any post-ictus cases.
Yes. Okay. Just I want to ask you if you heard of an inferior dislocation.
Yes.
Okay. And do you have any? The inferior dislocation is a very rare dislocation. But can you convince me this is an inferior dislocation rather than an anterior dislocation?
Yes, it is prominently inferior dislocation, but normally along with inferior dislocation, there is some interior displacement also. So it is normally associated with that. So I also mentioned the both.
Okay.
But it is predominantly inferior dislocation.
Right. What complications are you expecting in this patient? What should we look for?
We should look for peripheral pulses and neurovascular compromise. And this is the most acute and emergency complication which can occur with any dislocation.
Okay, and after they did reduction like this, what's the next step do you recommend?
I'll suggest an MRI to look for any labral injury and which can lead to recurrent dislocations.
Okay, nice.
A track athlete complains of pain, weakness, and decreased range of movement of his hip after hurdling. 15 years male. Okay, so this is a frontal projection radiograph of left hemipelvis, showing left ilium and left hip joint. I can see a well-defined detached bony fragment at the anterior superior iliac spine, and rest of the bones appear normal. There is the SI joint appear normal. The left hip is intact with the normal appearing proximal femur. So this is likely an apophyseal fracture, and this patient needs urgent orthopedic referral for further management.
Okay. What apophysis are you talking about?
This is anterior superior iliac spine epiphysis, and I think sartorius is attached to this epiphysis. I can't remember the exact muscle, but it needs urgent orthopedic referral for further management and pinning of this detached epiphysis, which can also cause the detachment of the attachments to it.
Okay. How about the iliac crest?
Yes, there is some detached bony fragment. It is a bit bigger than the only involving the anterior superior iliac spine. It is also involving the iliac crust.
Okay. Do you know what muscles attach to the iliac crest?
I think rectus femoris.
Okay. Next, please. Thanks.
Known case of AIDS, presented with wrist swelling and fever for 7 months, 11 years old male. These are frontal projection radiographs of both hands, in which I can see multiple ill-defined lucent lesions involving all the long bones, namely the phalanges, the metacarpals, and the distal parts of the radius and ulna. And these lesions are seen involving the diaphysis and also the metaphysis. I can also see that there is some periosteal reaction or along the diaphysis of the involved bones. I cannot appreciate any fracture. The patient has presented with pain. So I'll look for any fractures. The patient might be a known case, and I'll suggest if the previous radiographs are available, and look for any progression of these lesions. Patient is a known patient of AIDS. Along with this, I can also appreciate some soft tissue swellings. Keeping in view these multiple lesions with narrow zone of transitions, my primary differential will be enchondromas, multiple enchondromas, and I'll look for any previous imaging if available, and look for disease progression which has led to pain, because these have tendency for malignant transformation.
Okay. This is the elbow of this patient. Also has pain in the elbow.
And then, so this is a lateral projection radiograph of elbow of the same patient, in which I can see these diffusely scattered intramedullary lucent lesions involving the distal humerus, proximal ulna, and radius. And I cannot see any cortical break. I can also see some periosteal reaction. My further differentials might include fibrous dysplasia after looking at the involvement of these bones also. And the patient needs a skeletal survey to look for any other involvement, and to look for any associated deranged endocrinology.
Okay. I just want to focus about the soft tissue swellings. And you gave a good differential malignant transformation of the enchondroma, but so bilateral and with the soft tissue swelling and the pain, fever. I know this is a good differential. Another differential, can you give me for causes of swelling, soft tissue swelling, bone lytic lesion, and periosteal reaction?
Can be diffuse intramedullary metastasis causing which also appear similar, which can also appear similar, metastasis from thyroid or renal.
In an immune compromised patient like this. Do you think infection is a possibility?
It can be. Infections. Osteomyelitis can also occur in such patients.
Okay.
Morning
So,
stiffness.
sorry, so this would be the last case, okay? Thank you.
Morning stiffness, deformity of digits, rheumatoid factor positive.
Yeah.
45 years old female.
Okay. I don't know why it's.
This is a frontal projection radiograph of the female patient who has positive rheumatoid factor. I can see that there is a sclerosis and ankylosis involving the carpal, metacarpophalangeal, proximal interphalangeal joint with some involvement of distal interphalangeal joint also. And this is an erosive arthropathy with sclerosis. I can also appreciate I can also see some periarticular osteopenia, and there is significant reduced joint space at these joints with deformity at the metacarpophalangeal joints and proximal and distal interphalangeal joint, leading to Bottonier's deformities. So keeping in view a patient with such involvement, my primary differential will be rheumatoid arthritis, and further differentials might include osteoarthritis or psoriatic arthritis, and the patient needs urgent rheumatological referral for further management.
Okay, why do you think it's not psoriatic arthritis? What's about the distribution you don't like?
Psoriatic arthritis is more, there is more involvement of distal and proximal interphalangeal joints. There is predominantly new bone formation, and it can also cause penicillin cup deformity. And I cannot see any of these abnormalities in these in these joints, and also there is less involvement of the intercarpal and radiocarpal joints.
Okay, can this be an SLE arthritis?
Yes, it can be, but in SLE arthritis, also there is more involvement of distal joints.
Okay. Okay, it's fine for this case. You have time for another case?
Dr. Bada, no, then we will be squeezed for the rest of the people.
Okay.
It's already 57. So you can, I think, start with the feedback, huh? Okay. Thank you.
Okay, so this case was fine about detecting rheumatoid arthritis. It's the carpal bone fusion and this periarticular osteopenia, but you should more for, and the Bottonier's you got it quickly, but this is this cannot. This is when it's a simple case like this, I think the examiner would further question you about knowledge more in these cases. Like SLE doesn't have erosions, and you will not find fusion like this. But you did very well about the psoriatic arthritis. You can more distal than this. So in general, very good. The previous case, yeah, this is a tough, rare case, but so when if you somehow see this was maybe common very long time ago when TB was prevalent, but now it's coming back because of HIV and immune compromised. This is a presentation of TB, the musculoskeletal TB. It has a very strange name. This is Cystioides tuberculosis, because it has cyst-like appearance. TB in the musculoskeletal appearances, it has 4 types of appearances: cystic types, which like this. This is the more common type, and the infiltrative type, which is like another osteomyelitis, and the focal erosion type, and the spina ventosa, which is also comes in the exams. Just one one finger with the ballooning of the finger. The thing about this description, because patient is immune compromised and these are well defined, you gave a very good differential multiple enchondromas, but the fever, pain, soft tissue swellings that don't come with enchondromas. Very good, you said sarcomas transformation. It's one of the good differentials. But in this case, immune-compromised patient, first you should rule out that it is an infectious cause. This can be done by biopsy or aspiration and acid-fast stains. Okay. Previous. Okay, this case also very nice. When cases are easy to detect, I think more about the knowledge they will ask you what to do. This is very good. Anterior superior iliac spine avulsion fracture with associated extension into the iliac crest. So so it's not just limited to the anterior superior iliac spine, which is sartorius muscle. Also, this is the abdominal muscles attached to the iliac crest. This extension is common in track athletes. The whole avulsions are rare, but when you see both of them are fractured, it's more common with track athletes, especially when they just start running. The management is not immediate fixation. Usually, it's conservative, and for 3 weeks, and rest, and then on crutches for another 3 weeks. And the patient should have pain resolved and no further management required. But in athletes, or if the fragment is far away, more than 2 or 3 centimeters away, then they have to fix it immediately. This would have been a good observation that it's not very far. So just conservative management. Okay, this one also, it's easy. First, the presentation chest X-ray, maybe on the exam it will not be very clear that there is another pathology in the left, but it's nice after you finish the chest X-ray to look at the shoulders. It's inferior and sub to the glenoid. If it's inferior dislocation, it will be more under the coracoid. But in this patient, because clinically he was presented with abduction, and this humeral shaft is almost parallel to the scapular spine. So it's this is rare, but you have to know inferior dislocation of the shoulder. It's important because it's very common to cause neurologic and vascular compromise. Neurologic by axillary nerve and brachial plexus and either radial nerve, and vascular axillary artery injuries. As you said, we should do MRI after reduction, immediate reduction. We should not delay reduction. And it's associated with greater tuberosity fracture, and it's nice, better to evaluate Hill-Sachs and the Bankart and glenoid, especially inferior capsule on the MRI. It's very well done.
Thank you so much, Dr. Bada. Excellent cases, very nice cases. And thank you, Dr. Mamouna, excellent Viva. So now you guys can switch the seats. Dr. Mamouna, you can share, and Dr. Bada can act as a hot seat volunteer. I'll let you guys know at 13 minutes, which will be the last case, followed by the feedback. Thank you.
So, can you see my screen?
Yes.
I'm sorry, I didn't open them. So you can carry on, doctor.
Okay. So it's a pain and deformity of the wrist in a 30-year-old female patient. Okay. So I'm presented with the frontal view of the wrist radiograph showing the distal radius expansile or lucent region with the cortex in parts not clear, obstructed, and the associated soft tissue lesion, swelling.
Mhm.
Appears to be just limited to the distal radius. I would, in this patient, differentials include يعني شو اسمه Ewing eosinophilic granuloma, sorry, and azalytic lesion, giant cell tumor because it's subarticular, and the age is appropriate. Bone cyst, but it's very, it looks more aggressive than just a simple bone cyst, and also the soft tissue component. So the most likely, I think it's a giant cell tumor.
What will you do next?
I will refer him to orthopedic and for discussion in the MDT meeting.
So this is the MRI of the same patient.
Okay. So the MRI of the wrist is showing the same patient is showing the expansile lesion to have high T2, low T1, and high on stair, and it appears limited to the radius and not extending to other bones.
Right.
Some soft tissue edema around the region.
So your diagnosis is still a giant cell tumor.
Yes. Night pain subsided by analgesics for the last few months. 30-year-old male. So this is a lateral femur radiograph showing mid-shaft posterior cortical thickening. Can I see the zoomed view? Okay. So the zoomed view showing lucency most posteriorly. So in the patient with this typical presentation, osteodysteoma is my main differential diagnosis, and clinical correlation, and if required, ablation, radio frequency ablation. Okay. 5-year-old girl referred by her GP with ongoing pain of the right hand and wrist. No history of trauma. 5-year-old female. So this patient has ongoing pain of the hand and the wrist. It is a frontal radiograph of the hand showing loosened expansile lesions in the fingers, the proximal phalanges of the fifth, fourth, and third fingers. These lesions are well defined and not causing any cortical break, benign lesions. And there's also shortening of the metacarpals. They appear short. So, okay. Also, the ulna on the same side appears short. So I'm thinking of multiple enchondromas in this patient. These can cause length discrepancy and the expansile lucent lesions we're seeing, and also benign. Ongoing pain could be due to the ulnar negative variance. Bilateral elbow pain and swelling.
Sorry.
Okay, no problem.
It's fine.
So, so this is a lateral elbow radiograph of the right elbow showing calcification or increased shadowing in the calcific shadowing in the posterior aspect of the elbow, posterior to the distal humerus. This is in the location of the cranium bursa. Okay. Okay, so and this is only posterior, and I'm thinking maybe it's a bursal problem or soft tissue calcification. Could also be myositis, but it needs to have trauma in this location. So differentials include osteochondromatosis or tumor calcinosis or osteomyelitis ossificans. I'll compare with previous images if available and correlate with that. Okay, the right-sided backache for 3 months, 20-year-old male. Okay, so I'm presenting with the frontal radiograph of the pelvis of a 20-year-old male who has right-sided backache. I'm looking at the bones to find any lucency or fractures. Okay, I'm seeing spinal bifida at the L5 level. Looking at the iliac bone. I'm not seeing any sensing. And the iliac bones, hip joints are normal. The rest of the visualized lumbar spine appears normal.
Patient has right-sided pain.
Right-sided pain. Yeah, there is slight sclerosis in the right SI joint.
Mhm.
Yeah, I would. Okay. If right side, this is the only pertinent finding on the. Yeah, so just right SI joint slight sclerosis. If this is a long-standing case, maybe there's inflammation there. Although, yeah, 20-year-old asymmetric SI joint involvement, psoriatic arthritis, one of the main differential.
What
Or
other differentials?
Yeah, other differentials depends on the history. You know, if it's acute, it could be also infectious. If it's very long, it could be neoplastic. So
what will we do next?
if the patient is still available in the department, CT scan or MRI better. But yeah.
Yeah, provided with an ultrasound.
Ultrasound. So this is an ultrasound image showing with labeled source muscle, iliacus muscle, ilium, and there appears to be a complex collection. Yeah, it's labeled abscess. So there's an abscess at the right SI joint, right pelvis. Yeah, and I will just advise for ultrasound guided aspiration because it's accessible, and it's culture or and analysis. Right shoulder pain with limited range of motion, 30-year-old male. So this is a frontal radiograph of right shoulder showing the scapula having bubbly appearance, multiple lucencies, tiny lucencies within the scapula. I would advise for another view.
What's your diagnosis?
Well, yeah,
this is the only view provided.
Yeah, okay. So just by this, maybe this it's osteochondroma, يعني bubbly or cauliflower appearance. I'm thinking osteochondroma. Other differentials.
Any other differential you want to give?
Yeah, also if it's long-standing, it's yeah, osteochondroma. If it's probably a long-standing. Neoplastic, other neoplasms can occur. Chondrosarcoma, yeah, bone cysts, aneurysmal bone cyst. But شو اسمه, if it's if I the main one I'm thinking is osteochondroma.
Dr. Memuna, if you have a small case, you can have another one. Otherwise, you can start with the feedback.
Fall of mountain bike, tender thumb base, fracture suspected, 25 years. Okay, so this is left thumb X-ray showing fracture of the metacarpal base. It's Bennett fracture.
Fine.
I would call the orthopedic doctor and refer urgently for orthopedic management.
So this is a Bennett's fracture. It's a two-part fracture, and it's intra-articular fracture. So that is the reason it needs urgent orthopedic referral. This is I'll show you the case. This was the chondroblastoma of the scapula, and you were right, it's a lytic bubbly lesion, and your differentials were good, but you should also include chondroblastoma in it. And it can be a chondromyxoid fibroma also. This was unilateral sacroiliitis, and there was sclerosis at the right SI joint with loss of joint space. So the first two differentials of unilateral sacroiliitis includes infection. It is the most important one, and so otherwise you were fine. And on ultrasound there was a collection anterior to this SI joint, and it needs urgent aspiration. That one was you were fine with the giant cell tumor, and you gave good differentials with this case, and this is giant cell tumor. And this is 30 years old male with pain in the femur, and this is a case of osteoid osteoma with a lucent nidus in the center, and it needs radiofrequency ablation. And this is a 5 years old girl with ongoing pain, and there are multiple lytic lesions. And this case, I should also mention, is Madeline's deformity. These are multiple enchondromas.
What's the cause of it?
They haven't mentioned the cause of the pain, but in the case discussion, they have might cause pain, especially during the growth period. It's not necessary that there's fracture or any developing chondrosarcoma, but she's a 5 years old girl, so she might have developed pain due to she's in growth period. These were the cases. This one, yeah, the elbow one. This is a bilateral elbow pain and swelling. And this was the radiograph of bilateral periarticular calcifications And so this is a case of tumoral calcinosis, and they normally regress with when the steroid therapy is commenced. And in the further subsequent radiographs, they have shown that they have reduced.
Is there any special feature that led to this specific diagnosis?
They first rule out any other causes of these calcifications like calcium levels, and if everything else is fine, then they label it as tumoral calcinosis, and they improve with steroid therapy. These are the cases. Thank you very much.
Thank you so much, Dr. Mamoona. Thank you, Dr. Bada. So now we move to our next set of volunteers, Dr. Kanika and Dr. Sami. Dr. Kanika, can you please share your screen, and Dr. Sami would be the volunteer first for the hot seat.
Okay.
At 13 minutes, either the alarm you will be able to hear, or I will point it out, make it the last case so that we have time for the feedback. Okay.
Okay.
Thank you. We can see your screen, Dr. Kanika.
Oh, yeah.
But I think it's your last. Yeah. Your voice is breaking.
Hello. Can you
Yeah,
hear
now
me?
it's
Yes.
yes. Perfect. Do you
Okay.
have
Yes, please tell me.
do you have a Bluetooth or a mic with you? Because the
No.
voice is echoing, it seems.
No.
Okay, go ahead. Go
my
ahead. Go ahead.
own.
The screen is yours.
All right. So this is a case of left wrist pain, a female patient, 20 years old.
Yeah.
So should you give me the mouse? I'm already having the mouse.
I will do that.
Yeah. Okay. So this is a frontal radiograph of the wrist and hand of the wrist, showing an expansile osteolytic lesion involving the distal radius, reaching the articular surface, and the lesion is quite eccentric, associated with breaching or marked thinning and breaching of the medial cortex of the distal radius. The lesion has internal septations. However, there is no matrix calcifications, no obvious periosteal reaction, and there is no sizable soft tissue component associated. So diagnostic possibilities in this case would include a giant cell tumor and aneurysmal bone cyst are the main differential diagnosis in this case. So I would discuss the case with the referring physician. I may request MRI to check for the possibility of, I can see further maybe fluid levels, which could suggest the case of a diagnosis of aneurysmal bone cyst over a giant cell tumor. That's it.
My question is that can we have giant cell tumor and then some component of ABC in it?
Yeah, actually, the ABC could be a primary one and could be a secondary one on top of the giant cell tumor. This is the same spectrum of the disease, actually. The giant cell tumor and the aneurysmal bone cyst, the same spectrum of the disease. Yeah, so we can have pathologically, we have can have some kind of overlap between both diagnoses. Okay.
Is there any other differential comes to your mind when you see an epiphyseal lesion?
Epiphyseal lesion, actually this lesion happens in a skeletally mature patient, apparently skeletally mature patient. So the lesion is reaching the articular surface. If before the epiphyseal closure and the lesion is happening in the epiphysis, I would consider the chondroblastoma rather than the giant cell tumor and the aneurysmal bone cyst. Otherwise, we have a list of the differential diagnosis of such lesions, including could be the fibrous dysplasia. However, this could be a smaller in size and more cortical, with no have usually will not have this larger medullary encroachment, and the non-ossifying fibroma the same. Brown tumor also could be a possibility if the case known to be having hyperparathyroidism or primary hyperparathyroidism or secondary one. So brown tumor could be a possibility also. However, in this case, we should see some maybe periosteal tunneling and cortical tunneling or subperiosteal erosion in the phalanges, which are not imaged here, or maybe even the carpal bones, metacarpal bones, but I don't see any of this. And also in the hyperpara, we could see some calcifications at the region of the TFC, but also this is not apparent here.
Okay. Move on to the next case.
Yeah. So this is a female, 65 years old female patient, presented with discharge from the skin of the right mid-thigh.
Okay.
This is multiple projection of the right femur in the AP and lateral views. So at the middle third or middle to distal third of the right femur, I can see altered modeling of the femur with ill-defined mixed lesion centered on the medullary cavity with central lucency and surrounding ill-defined sclerotic changes associated with the focal expansion of the bone and some cortical or endostal thickening. However, I'm not sure if there is any cortical breaching or no. There is no sizable.
These are the other ones.
Yeah, I'm not sure to judge about the cortical breaching or associated fracture in these views. And considering that the patient came with a discharging sinus at the mid-thigh, so I would consider the possibility of inflammatory or infectious process like Brody's abscess, osteomyelitis spectrum like the Brody's abscess. So I would check if the patient has a previous history of the osteomyelitis before. I would request also, of course, after discussing the case with the referring physician, would request cultural sensitivity from the bus or from the discharge. So this is my differential diagnosis in this case, considering the age and the clinical presentation.
Okay. So which osteomyelitis do you think in this? Acute osteomyelitis or chronic osteomyelitis?
The case is discharging right now, and we have sclerotic changes. So I suggest this is a chronic osteomyelitis case based on the expansion of the bone, the sclerotic changes. And so I think this is a chronic osteomyelitis.
Okay. So in the chronic osteomyelitis, what is the, can you see any sequestrum in this?
In this case, there's some ill-defined sclerotic areas inside this lucency,
Okay.
but maybe not clear on the shared screen. But this one could be representing a sequestrum actually. This ill-defined sclerosis within the central lucency.
Okay.
So if this, I would go more with this sequestrum inside the lesion. So this proved the idea or the diagnosis of the chronic osteomyelitis.
Okay.
So this is a male patient, 80 years old, who presented with chronic right low back pain He had polypectomy 17 years ago due to colon cancer, which was T1-NOMO. All right. So this is a frontal radiograph of the pelvis and right hip joint. So there is ill-defined pathological process involving the right hemipelvis, mainly involving the acetabulum and the pubic rami in terms of multiple osteolytic lesions of variable sizes. There is mild periosteal reaction along the pubic rami as well associated. There is no obvious fracture. May I see the oblique view, if you
Yes,
don't mind?
yes, please.
All right. So again, it demonstrates the same findings. So we have predominantly osteolytic lesion involving the previously described bony structures. In the view of past history of colonic cancer, okay, this is a bony scan, MDB bony scan showing increased uptake or hot uptake at the same region shown on the radiograph. There is no other lesions. The kidneys uptake are there, as well as the bladder uptake. So diagnostic possibilities include Paget disease and metastasis, chondrosarcoma, osteosarcoma. These are the diagnostic possibilities of the case. Considering that there is kind of bone expansion at these affected bones, so Paget and some coarsening of the trabeculae, I would suggest Paget disease as a primary differential diagnosis in this case.
Yeah.
That's it. So this is a male patient who is 20 years old, complaining of left knee pain since a few months with mild reduced range of movement. So this is a frontal and lateral radiograph of the left knee. Sorry, he's 20 years old.
Yes.
Yeah, 20 years old, right? So I suggest that there is kind of delayed closure of the epiphysis in this age, and there is kind of soft tissue swelling in the knee joint. Let's see, just the lateral, if you don't mind.
Can you see?
Could be kind of enlargement in the femoral condyles, and with ill-defined lytic, mixed lytic and sclerotic changes in the medial femoral condyle. I'm sorry, I cannot give any more explanation for this case.
So what are your differential on the basis of the lesion in the epiphysis in young age?
So in this age, the lesion involving the epiphysis, and this was before the closure of the physis, I would consider chondroblastoma as a primary differential diagnosis. If the case is more acute, I would consider the osteomyelitis as well. These are the two differentials which come to my mind.
Okay.
So this is again a male of 20-year-old who came with scalp swelling in the left parietal region without any without pain and fever.
We'll make this the last case. Okay, thank you.
Right.
Okay.
So we have this is a lateral radiograph of the skull. we have a well-defined osteolytic lesion involving the left parietal bone. The lesion has beveled edges. So and there is no other lesions. I cannot appreciate any pathologic calcifications. So in this case, I would consider. I'm sorry, how old is the age? 20 years old.
20.
So we may consider the eosinophilic granuloma as one of the differential diagnoses. Other diagnostic possibilities would include metastasis or multiple myeloma. However, this could be in a older age group or with a non-primary. Eosinophilic granuloma is the first differential diagnosis in this case.
Okay. So basically you did really well. I don't think I need to explain anything. So as you see, this is because this is a young boy. So the differential is eosinophilic granuloma, whereas if it would have been an older population, then we'll go for plasmacytoma or metastasis. Then in this case, you rightly said that this is chondroblastoma. So we just have to give the differential of the lytic lesion. As you rightly said, you will rule out infection. And, in this case, the thing is that I think this is a red herring that this patient got polypectomy 17 years ago, that to 17 years ago, and it was just a T1. So basically at the age of 80-year-old male, the Paget's disease is more common given the history, which was just T1 and 17 years back. So as you rightly said at the end, that there is coarse trabecular markings with expansion. So that goes in favor of Paget's given the nuclear study also. So this was a Paget's disease. And so this was, as you rightly said, it is chronic osteomyelitis with sequestrum in the middle, and then there is actually the sinus is not very well seen here, but this is the sinus tract. It's not very well seen, of course. So this was chronic osteomyelitis, and this was GCT. So basically the GCT and ABC are disease of the same spectrum. So sometimes we can also see like fluid-filled cysts when we do the CT scan of these patients. So it's the same spectrum. This was GCT. You did really well. Yeah.
Thank you, Doctor.
Yeah.
So,
Thank you very much, Dr. Koenig and Dr. Sami. Now you can switch roles.
So I will share my screen.
Yes, please. Okay, go ahead.
Yeah, can please proceed?
Yes.
Please.
If you want to give you the mouse, it's okay. I mean,
no, it's okay. You can change. That's okay.
All right. Okay.
So it is. This is history of bilateral hand swelling and tenderness in a 78-year-old female.
So this is the right hand and the frontal radiograph of the right hand, and this is the frontal radiograph of the left hand.
Okay, so I can see that there are joint space reductions at the DIP joints and PIP joints, and there are seagull wing appearance in the PIP joint of the index finger, and there is the MCP joints and the carpal joints are not involved, and there are soft tissue swellings around the joints.
All right, you pointed out all the important findings. So what's your differential diagnosis in this case?
The top differential in this case would be an erosive osteoarthritis,
Right.
and my second differential will be osteoarthritis,
You mean degenerative osteoarthritis?
degenerative, but that would be my second differential.
So what
And
again is the osteoarthritis, the degenerative osteoarthritis in this case?
can you please repeat the question?
What's again is the degenerative osteoarthritis in this case? What favors the erosive osteoarthritis over the degenerative osteoarthritis?
In the index finger, I can see that there is like seagull wing kind of appearance, which is not seen in case of degenerative osteoarthritis, and it mainly involves the DIP joints and
So
MCP.
is it the distribution or is it the erosion? What's against? What favors the erosive osteoarthritis over the degenerative? The distribution or the erosion?
Erosion. Erosion is not in favor of osteoarthritis.
Great. So any other differential diagnosis?
Mm, the differential diagnosis, it can be
Actually, this patient presented with morning pain and stiffness. So
okay.
based on the clinical presentation, so any other differential diagnosis?
It can be because of rheumatoid arthritis.
Correct.
But rheumatoid will have periarticular osteopenia and no newborn formation.
Great. Great. Move to the next case.
This is a 10-year-old female presented with generalized leg pain and specifically right ankle pain, stopping activities at school and requiring non-involvement in school games. Right ankle pain.
Right. So I will start with the X-rays first.
This is a frontal radiograph of the left ankle, and of a 10-year-old girl. Talus appears normal, and the tibial distal end appears normal.
Okay.
Femoral
Great.
distal end
It's actually normal. Yeah.
Yeah.
So I will move for the cross section. So we have actually here stair images for the entire lower limb, both
Okay.
lower limbs. So actually this is the starting from the femur.
Okay.
Then we'll move a little bit down.
The metaphysis of bilateral tibia appears shows high intensity on a stir image, and similarly the epiphyseal region of bilateral tibia also shows high intensity.
Let me show you also this one.
So bilateral femoral and tibial epiphysis shows high density and high intensity, and the lower end of distal tibial and fibula also shows high intensity. So
So I have bilateral, symmetrical, abnormal high signal intensity in the stair images involving the distal ends of the femora, proximal ends of the tibia, and fibula, as well as the distal ends of the tibia.
yeah.
Yeah.
So I'm not able to recall anything based on this.
So this patient presented with actually with pain, and which prevented the patient from participating in the activities. He's a child, so what comes to your mind in such cases?
Like any stress fracture can happen, but this is unlikely with this presentation. And
Why unlikely? The presentation or the, I mean, the appearance in the MRI?
the appearance.
The appearance, okay.
And stress fracture can happen, or this can be
Can infection happens in the same, I mean, with the same disappearance? Infection.
There is a chronic recurrent osteomyelitis in kids, but this is not the appearance. I mean,
So what's the appearance of the recurrent osteomyelitis?
so basically, it will not be so symmetrical and involving so much of so many joints. So
Any other thoughts?
nothing is coming in my mind. I think I can not correlate.
No problem. So we'll move to the next case and come back to this case on the feedback.
Knee injury while playing football, restriction of movement and anterior tibial tenderness in a 15-year-old male. So this is a frontal radiograph of the knee joint, right knee joint in a skeletally immature individual. I can see that there is a lucent lesion in the metadiaphyseal region of the mainly diaphyseal region of the tibia anteriorly, and this has a prominent sclerotic margin, and most anteriorly there is a lucent lesion, this lucent lesion of around 1 centimeter, and
How about the zone of transition?
it appears it has a narrow zone of transition because I can see the sclerotic margin, and there are no aggressive features like periosteal reaction or soft tissue swelling.
Correct.
So this
your
goes,
differential.
given the history and the features on the X-ray, this goes mostly in favor of any bone infarct, but bone infarct, or it can be
So, I mean, you have predominantly you have an osteolytic lesion in the tibia with some sclerotic changes. So, and without any aggressive features, as you said. So, I mean, great.
Or
in the anterior tibial cortex, we have another lesion which is quite characteristic to dislocation. Adamantinoma is a correct differential. The other lesion which comes in this place or this location, characteristically also is the chondromyxoid fibroma.
Yeah, chondromyxoid fibroma.
We have more, more erosion in the anterior cortex.
Yeah, but the age is same.
You know, the age, we can play with the age. I mean,
Okay.
we can play with the age. So, yeah, I mean, so is it a benign tumor? The adamantinoma is a benign tumor or a malignant tumor?
Adamantinoma is basically it's a malignant tumor.
It's low-grade malignancy, but so it has also the ability to, or the power to metastasize to the lung, liver, and bones as well. So any other differential diagnosis for this case apart from the chondromyxoid fibroma and the adamantinoma? In also considering the age group?
I mean, so nothing is really coming to my mind except for that.
We'll come to it later.
Low grade.
So next case.
So it's a painful swollen left knee in a 50-year-old male. Okay, so I can see that there is a frontal and lateral radiograph of the knee joint, and I can see there is effusion, knee joint effusion, and There are no features of osteoarthritis in this knee joint, and
So, what do you think about this and this?
okay, so there are some periosteal reaction around the upper tibia and fibula,
And
and
as well as here, you can see it here also. Maybe interrupted and not continuous, but we have here also. And on the
sometimes it is seen in case of venous insufficiency,
great.
but
So this is one of the differentials, correct?
yeah.
So any other differential?
Any other differential?
This is an effusion or fullness in this one? I mean, are you sure this is an effusion? Because the patient doesn't have actually osteoarthritis.
Yeah.
So, this may be just a fullness, maybe some soft tissue, something like this. I mean, you are not sure that this is an effusion or not.
Okay.
So you have mainly you have a periosteal reaction involving the visualized bones, and you pointed out that this is may happen with the venous insufficiency. This is correct. So any other differential?
It can be cellulitis because the skin is thickened.
Yes. Okay. But cellulitis is an acute process. It will not result in periosteal reaction.
Yeah. And other things.
So this might be a thyroid acropathy as well.
Yeah, in thyroid acropathy also we'll see this kind of edematous changes.
The third differential is the hypertrophic osteoarthropathy.
Yeah,
Okay, so this is actually a case of hypertrophic osteoarthropathy. So what are the causes of the, we have the primary hypertrophic osteoarthropathy and we have the secondary hypertrophic osteoarthropathy. So what are the causes which come when, I mean, can result in the secondary?
Pulmonary causes like bronchiectasis, pulmonary pleural fibroma, or bronchogenic carcinoma, and also it can be associated with the renal failure and
Okay, so this patient, we did for him the nuclear scan, and we did for him CT first, by the way, and we found this lesion,
okay,
the condyle, and if you go back for the X-ray, actually you find this small osteolytic here as well.
okay.
And after this patient went for CT scan of the chest, where we found this middle lobe mass with consolidation. So actually this is a bronchogenic carcinoma with secondary, in this case, the hypertrophic osteoarthropathy is a kind of paraneoplastic syndrome.
Okay.
I think Dr. Sabhat, the time is over, so I will go for the feedback from the last.
Please. Thank you so much. Yeah.
So as we said, this is a case of secondary hypertrophic osteoarthropathy, secondary to or as a sign of paraneoplastic syndrome, secondary to middle lobe bronchogenic carcinoma with secondary lung collapse, middle lobe collapse. The previous one was the football injury, and 100% your differential was correct. This is a case of adamantinoma, and the differential is the MRI of the case, if you are interested to see. And the differential of this case would be the chondromyxoid fibroma and the fibrous dysplasia.
Okay.
Actually, I feel that we neglected the part, quite the management part, but just to see more, show more cases. It's a case of generalized leg pain, and actually you pointed out the differential or the diagnosis of the case. This is a case of recurrent multifocal chronic recurrent multifocal osteomyelitis.
Okay, so it's quite symmetrical.
Yeah, you pointed it out, but I'm not sure why. I mean, you said it is not, but actually this is.
Because it was quite symmetrical. I thought
yeah,
that it would be.
You are right, but I mean the differential in this case would be, I mean, you have to exclude the Ewing sarcoma in this case, and leukemia as well. You have to exclude because I mean the CRMO is a quite of diagnosis of exclusion. So we need to exclude other causes like the Ewing sarcoma and hematogenous osteomyelitis.
Okay.
And this one with the bilateral hand swelling is an erosive osteoarthritis. and you pointed it correct. So thank you, doctor, and you did really very well.
Thank you.
Thank you so much to all the volunteers who acted as examiners and examinees. Excellent collection of cases. I hope everybody found it useful. So good night, everyone, or good afternoon, wherever everyone is, and we'll see you next time, inshallah. Thank you so much.